This explainer is based on the literature review, Vestibular Function Testing Interpretation for Physiotherapists, vHIT, Caloric Rotational Chair, VEMP, published by Australian Dizziness Clinics, available at australiandizzinessclinics.com.
All right, let's jump right into it. Today, we're unpacking what is arguably the single highest yield clinical breakdown for vestibular physios. We're going to bridge that frustrating gap between those highly technical vestibular function testing reports and your actual targeted exercise prescriptions. So let's make some sense of these numbers.
Picture this, a scenario you've probably seen 100 times. Two patients, patient A and patient B, walk into your clinic. Both have the exact same dizziness diagnosis, right? And both get the identical generic vestibular rehab therapy. But look at the completely different outcomes. Patient A recovers beautifully in just 4 weeks, while patient B, well, they just plateau indefinitely. So why the massive difference? It all comes down to the fact that the therapist for patient A actually read the vHIT report canal-by-canal, instead of just kind of throwing a generic peripheral weakness dart at the board.
Here is our roadmap for today to make sure you are always the therapist for patient A. 1. Reading vHIT gain in Saccades. 2. Phenotyping the lesion. 3. Turning numbers into a prescription. And 4. The frequency gap.
Section 1. Reading vHIT, gain and Saccades.
This requires a complete paradigm shift for us as clinicians. The VFT reports are not just a simple pass or fail. Every single numeric pattern maps to a very specific rehabilitation lever. Honestly, if you take away just one thing from this explainer, let it be this. Reading the actual numbers replaces generic guesswork with precise, mechanism-targeted dosing. We're not just scanning for a normal or abnormal box to be checked, we're hunting for the patient's specific mechanical blueprint.
So the absolute crucial starting point is this magic number right here, 0.8. When you're testing the vestibulo-ocular reflex, the VOR, a normal gain sits between 0.8 and 1.0. Any value dropping under 0.8, that instantly equals canal hypofunction with a peripheral signature. That right there is your baseline threshold for action. Now here's what that number actually looks like in real time. Take a look at the trace. See that green line? That's the normal eye velocity, just smoothly matching head velocity, hitting a healthy gain of about 0.95. But check out the red line underneath it. It shows a really sluggish gain of 0.55, meaning the eye is severely lagging behind the head. And you catch that secondary red curve popping up right after? That's the eye desperately snapping back to find the target. That little snapback is called a refixation saccade. These are literally the bedside fingerprints of peripheral hypofunction. Now, they can be covert, meaning they happen right during the head turn so fast you can't even see them with the naked eye, or they can be overt, happening right after the head stops moving. The key thing to remember here, even if your gain number is hovering on the borderline, the presence of these saccades absolutely confirms the deficit. No question. Section 2. Phenotyping the lesion. Okay, this matrix is where the clinical magic really happens. Remember, the vHIT tests all 6 canals individually. So if you spot a combined lateral and anterior loss, you're likely looking at superior division neuritis. What does that mean for you? It tells you the otoliths are spared, and your rehab should focus purely on adaptation. But what if you see bilateral lateral loss? Well, that's bilateral vestibulopathy, and you've got to completely pivot to substitution. And posterior loss only? That's super rare and points directly to inferior branch involvement. You see how these specific combinations literally pinpoint the anatomy and drastically alter your treatment path? Section 3. Numbers to prescription. Let's ground all this theory in a real-world clinical prescription. Say your report shows a right lateral gain of 0.5, plus you've got saccades present. You don't just tell the patient to move their head while looking at a dot. No, you specifically prescribe affected plane VOR times 1 or times 2 at 1 to 2 Hz. A low right lateral gain strictly dictates horizontal yaw plane drills. And building on that, remember that each canal's gain prescribes its own very specific rehabilitation plane. A lateral loss absolutely requires yaw plane, the side-to-side no head turns, but an anterior or posterior loss, that requires pitch plane, the up and down yes head turns. So if your patient has an affected right anterior canal, standard horizontal exercises just aren't going to cut it. You have to add pitch plane drills to actually hit the deficit. Once you've nailed down the plane, here is the exact progression protocol you need for gaze stabilization training when adopting a unilateral deficit. Step 1. Start with VOR times 1 at 1 to 2 Hz. Step 2. Only add times 2 viewing once that times 1 stays perfectly visually clear for the patient. And step 3. Progress their velocity, then the amplitude of the movement, and finally the context, like, say, doing it against a really busy checkerboard background. But hold on, remember our phenotype table from a minute ago? If bilateral lateral canal loss is present, you absolutely must pivot. Adaptation strategies simply are not going to work here. You have to shift your entire program over to substitution VRT. This means relying heavily on training anticipatory saccades, leveraging the cervical ocular reflex, and maximizing proprioceptive cueing. It's a fundamentally different approach for sure.
Section 4. The frequency gap and key takeaways.
Take a close look at this test coverage chart because it contains a massive clinical pearl. The vHIT only reads a high-frequency band of 1 to 6 Hz. That is incredibly fast head movement. So why does this matter to us? Because a perfectly normal vHIT absolutely does not exclude peripheral pathology. A patient could very easily have a low-frequency deficit that the vHIT simply cannot pick up.
So let's rapidly summarize the core takeaways you can start applying in your clinic tomorrow morning. First, a vHIT gain under 0.8 plus refixation saccades equals guaranteed canal hypofunction. Second, always phenotype the lesion by reading the specific 6-canal pattern. Third, remember that a bilateral loss flips your rehab straight to substitution. And lastly, to cover that frequency gap we just talked about, always pair your vHIT findings with caloric testing.
In Part 2, we cover caloric testing and rotational chair, Jonge's canal paresis, directional preponderance, and how rotation fills the mid-frequency gap between calorics and vHIT. For more resources, literature review, clinical cheat sheet, audio overviews, and the rest of this series, visit AustralianDizzinessClinics.com. Please subscribe and leave a rating.